So I wanted to focus our discussion today on the more common vascular compression syndromes that we see that tend to be focused within the abdomen. So what vascular compression syndromes are, it's a group of disorders that are characterized either by compression of a vessel or the vessel compressing on an adjacent structure. So the ones I wanted to focus on today, we'll start by talking through superior mesenteric artery syndrome, where the SMA compresses the third portion of the duodenum, move on to median arcuate ligament syndrome, where the median arcuate ligament of the diaphragm compresses the celiac artery, Thurner syndrome, or Thurner, depending on where you trained and where you practice, where the right common iliac artery compresses the left iliac vein, and then finally Nutcracker syndrome, or left renal vein compression syndrome, where the SMA compresses the left renal vein. So starting with superior mesenteric artery syndrome, all right, so in normal anatomy with normal intestinal rotation, the superior mesenteric artery courses above and superior to the third portion of the duodenum. And the duodenum is typically protected by a nice rind of mesenteric fat. Okay. However, with loss of that retroperitoneal fat pad, you can get compression of the duodenum between the superior mesenteric artery and the abdominal aorta. So what are the predisposing conditions that we see this condition in most? We think about it mostly in patients who've had some sort of excessive weight loss, whether that's been an intentional or an unintentional weight loss. But it's also important to remember that our patients who have some anatomic abnormalities might also be predisposed to this. So some of our patients with pretty severe scoliosis, just from the distortion of their mesenteric anatomy, secondary to their spinal curvature, they can also be predisposed to this. There's also an anomaly where you can get a relatively high insertion of the ligament of Treitz, and that would move the duodenum more superiorly. And then also remember postoperative changes to the anatomy, whether patients have had prior abdominal surgery. Some of those things can also predispose to this. And clinically, we should really be thinking about superior mesenteric artery syndrome in patients who are presenting with postprandial epigastric pain, nausea, vomiting. They're just unable to tolerate having too much in their stomach because the duodenum is obstructed and they're having poor gastric emptying. So when it comes to imaging for suspected SMA syndrome, ultrasound is often not the first thing. So ultrasound is often done in conjunction with several other imaging modalities. Abdominal X-ray is almost always the first thing because that's just what we do when kids have abdominal pain. And there are some findings like marked gaseous distension of the stomach, or you can sometimes even see marked gaseous distension of the proximal duodenum. But for the most part, most abdominal X-rays are relatively normal. Fluoroscopy, which is where I feel like we see SMA syndrome being questioned the most, is helpful because it does give you dynamic imaging of the duodenum, and you can actually assess for obstruction. But really, it's ultrasound or cross-sectional imaging where we can really make the diagnosis and confirm what we might have suspected on fluoro, because we're actually going to look at the aorto-SMA angle as well as the aorto-SMA distance. So here's an example case to get us going. This was a 12-year-old female who had a history of prior abdominal surgery, had had a closed loop bowel obstruction, but that was in the past. And she was now presenting with ongoing weight loss post-op and having worsening emesis. And so her abdominal X-ray initially gotten as part of her workup is reassuringly quite normal looking. You can see she has some postoperative changes, but otherwise a very normal bowel gas pattern. But she went on to an upper GI, and you can clearly see that this first and second portions of the duodenum are very, very dilated. And there's almost a band-like impression overlying the spine of that third portion of the duodenum, okay? However, after several minutes, contrast was seen passing into the more normal caliber distal duodenum and the proximal jejunum. So this is really that imaging finding that on fluoroscopy should make you say, oh, I bet this is superior mesenteric artery compression, because the diameter change is so distinct. And there's this really kind of obvious, almost obstruction that you can see on the fluoroscopy. So the next step in this diagnostic journey was ultrasound. And so here what we can do is get really beautiful longitudinal images of the aorta, right where the celiac and the SMA arteries arise. And so what we're seeing here is that the SMA has a very narrow band of fat between the anterior abdominal wall, and that aorto-SMA angle between the two is very, very, very small, okay? This angle should be greater than 25 degrees. So this was measuring at 8 degrees. In a different patient, this is now a 16-year-old who has a prolonged history of right upper quadrant and abdominal pain. This was her ultrasound. She actually went to ultrasound first, which was a little surprising to me, but also kind of nice. And you can just see on the grayscale image alone, you know, that you can see the SMA coming off really nicely from the elongated proximal abdominal aorta. And when we go to do the measurements, so in this case, right, again, when you do these angles, by definition, you're going to draw the first part of your angle line along the posterior wall of the proximal SMA, and then your second line along the anterior wall of the abdominal aorta where the two vessels meet. And that will give you your aorto-SMA angle. So in this case, in this 16-year-old, the aorto-SMA angle was 15 degrees. Again, remember that angle should be greater than 25, okay? And then if we were to measure the actual distance between the aorta and the SMA, so actually measuring the fat plane there, we only get 2.4 millimeters. So this should be somewhere more around 12 millimeters. So this is quite narrowed as well. And then the fluoroscopy to follow it up. On the upper GI, you can see that dilated proximal duodenum. In real time, you'll often see to and fro peristalsis as the contrast is being pushed back and forth because it can't cross over due to the external compression. Now, as we become better and better and better at looking at this portion of the body with ultrasound, we've got HITWE here. So of course we know that we can very easily assess the duodenum on ultrasound. There are starting to be more reports of actually assessing for duodenal dilation on your ultrasound exam as well. I don't have one yet from our practice. This is one that is actually from the literature, and if there's anybody who's interested in reading about this case, this is a QR code that should take you right to the publication. But I thought it was a beautiful example of really the breadth of pathology you can look at in SMA compression. Because here's the images that I just showed you, which is the very classic approach just to look at the vessels. But so here you see that aorto-SMA angle. But we also know that with really good ultrasound technique, you can clearly see this dilated third proximal duodenum, and as it really narrows down between the SMA and the aorta. So we've actually started to incorporate this a little bit into our practice here at CHOA. This is our protocol for targeted evaluation of superior mesenteric artery syndrome. We do ask that these patients be NPO prior to coming to the department. And these are our NPO guidelines there if anybody is interested in them. We have NPO guidelines that are age specific and a little bit more specific to developmental feeding and how often patients eat at different ages. But really, it's a very focused exam. We spend a lot of time looking at that proximal aorta and looking at that aorta-SMA angle. We get still and cine images. We do grayscale and color. We do put pulse wave on there, not necessarily because it's required. It's not really necessary. But my sonographers get twitchy when they're not putting a Doppler, a pulse wave on an artery. So we have them do it because it makes them feel like they're doing what they're supposed to do. And then we've added in this trans midline cine, and that's to try to really capture that duodenal compression. So we ask our sonographers to do similar imaging to what we are now doing for intestinal rotation and for volvulus as well as for SMA. So we do a trans cine basically from umbilicus to bladder dome. We do it as a double screen image. So we have grayscale on one side and color on the other so that we can assess all of the vessels and all of the anatomy as well. All right, moving on to median arcuate ligament syndrome. So the median arcuate ligament is a fibrous band that bridges the diaphragmatic crura, right? And usually it sits above the celiac artery origin, somewhere around the L1 vertebral body. But if it's too low, it can actually arise right at or just below the celiac artery origin. And then you actually get compression of the celiac artery by this crossing median arcuate ligament, okay? And if the ligament is too low, as the diaphragm does its diaphragm thing, you can get dynamic compression of the celiac artery. So, and this is a really nice diagram from StatDX. It's the best I've ever found. So it's the one that I use. So here you can see this is a kind of cross-sectional of this picture here, showing you that this is a low position of the median arcuate ligament. And during expiration, as the diaphragm actually moves dynamically, you can have increased compression on that celiac artery. So this is really important. I want to say this one more time. Okay, so compression of the celiac artery is worsened on expiration. So that's one of the things that we're going to look for when we actually do our ultrasound evaluation. So compression of the celiac artery results in, we think, a transient mesenteric ischemia. There's some other theories out there, and this is a very rare syndrome. It's like 1 in 500,000, something like that. And so we're still very much understanding what this whole median arcuate ligament syndrome is about. What we know is that clinically, we typically see this in very thin young adults. It's very female predominant. They will have variable symptoms though. Often they're complaining of nausea. Often they're complaining of intermittent epigastric pain. It's more commonly postprandial, which is why we think that there's probably a mesenteric ischemia component to it, as the blood flow through the celiac artery is upregulated after eating, and therefore the compression decreases the amount of mesenteric flow. We will also see this in patients. They will have weight loss because they're really not able to tolerate eating. They just have too much pain. So these are the typical clinical presentations, and often these patients have gone through the ringer. They've gone, and because this really is a diagnosis of exclusion of all the other things, really before we get to this median arcuate ligament syndrome, because it is, in fact, such rare anatomy. But ultrasound plays a really important role. We use ultrasound a lot here at CHOA for this diagnosis, because we can not only look at the morphology of the celiac artery, we can also look at Doppler flow patterns to see if there's any turbulence from the compression. And similar to what we would look for in renal artery stenosis, we can actually look at peak systolic velocities. The other thing that's beautiful about ultrasound is you can do it in inspiration and in expiration. So you can really test to see if there's major changes between those two states. So in terms of what we're looking for, morphology of the celiac artery. So all of this is based on this one seminal paper by Gruber et al. This is the reference that we use. This QR code will get you to that reference. So an abnormal deflection angle of greater than 50 degrees, meaning the aortic celiac artery angle, the deflection angle, but also specifically narrowing at the celiac artery origin with post-stenotic dilatation, true post-stenotic dilatation. Flow turbulence in the portion of the celiac artery that is getting compressed. And then we use very specific peak systolic velocity measurements. So remember, peak systolic velocity will increase as the narrowing is increased. So what we're looking for is a dynamic change in peak systolic velocity between inspiration and expiration. And we use these numbers because they're the numbers in Gruber. If the peak systolic velocity is greater than 350 centimeters per second, that's equivalent to a greater than 70% stenosis. If peak systolic velocity is between 200 and 240, it's greater than 50% stenosis based on this paper. But the way I like to teach this to my residents, because I hate memorizing numbers, in renal artery stenosis, we're often talking about the renal aortic ratio. So that's one of the things that we actually also do in our practice for median arcuate ligament syndrome. Remember that your velocity should get less and less as you get further and further away from the heart. So if the peak systolic velocity in the celiac artery is greater than 2 times that of the abdominal aorta at the same level, that's indicative of a significant stenosis. So if you don't want to remember the numbers, just remember that ratio, right? Renal aortic ratio is a 3 to 1. Here we tend to do 2 to 1 just because we have to have a little bit of a higher sensitivity, but 3 to 1 would also work. All right, so what do we actually see? So this is probably the best case of median arcuate ligament syndrome I have ever come across in my practice. So this is the one that I will always present when I talk about this. So this was a 16-year-old female who had chronic abdominal pain and had a very exhaustive workup. She had a normal upper GI. She'd had multiple normal ultrasounds. And so with all of that coming back normal, she came to us from the GI clinic to evaluate for possible median arcuate ligament syndrome. So I want to show you, this is not the greatest still picture, but it's a beautiful pulse wave Doppler. And here we are at the level of the proximal celiac artery, okay? And I want you to notice that the peak systolic velocity is around 200, okay? This is supine in inspiration, and that should be in maximum inspiration. Take in a big deep breath and hold it. Get your picture, measure, let them breathe. And this is what happens on expiration. So expiration is blow out your breath, hold it out, hold it out, hold it out, okay? And this is a much nicer still picture where you can really see this kind of hook appearance of that celiac artery right at its origin. You can see on the color the degree of turbulence that you're getting within that narrowed portion, all right? And then you can see that the peak systolic velocity has changed dynamically and gone up, and it's now 250. So this is high in inspiration, but it's higher, even higher in expiration, indicative of median arcuate ligament syndrome. Then we moved the patient into the standing position, and we imaged in standing, and we imaged in compared that to supine imaging. So why standing up and sitting down? Well, this helps us tell the difference between a true MALS and the alternative, which was an equally rare fixed stenosis of the celiac artery. So by definition in MALS, and a lot of this goes back to that Gruber reference again, but we've noticed and we know that when the patient is supine, okay, gravity is actually going to pull that diaphragm down ever so slightly. Whereas when they stand up, their diaphragm is going to lift up as well. And in fact, and the other thing that happens, because we've all seen this on KUBs, the difference in the orientation of the bowel, right? When you're standing versus when you're lying down, and the bowel actually moves down, that actually helps to pull the celiac artery down a little bit too. So by definition, standing should decrease the amount of pressure that's exerted on the arcuate ligament. So documenting dynamic changes in flow velocity and vascular morphology on standing versus supine is there to actually improve our diagnostic confidence that yes, in fact, this is median arcuate ligament syndrome. And so here you can really nicely see the change in morphology of the proximal celiac artery. It's still narrowed and there's still some turbulence, and it's still not a totally normal peak systolic velocity, but it's better when she's standing than when she's lying supine. So we put all of those pieces together, and the whole picture is suggestive of median arcuate ligament syndrome. These patients will typically undergo additional diagnostic imaging. CTA is what we prefer. So here is this patient's CTA, and you can really nicely appreciate the degree of narrowing at the origin of the celiac artery and the amount of post-stenotic dilatation, okay, and that abnormal, very narrow angle of deflection. And for the cherry on top, some similar findings we're seeing on the diagnostic angiogram. So this patient did go to the operating room. These are pictures from our surgeon. This is why I like this case so much. And what they typically see in the median arcuate ligament syndrome, I'm going to go back one slide so you can see this. So yes, there's vessels here, but remember there's also lymphatics, right? Your thoracic duct and your central draining system is all right here. So you'll have they'll get lymphatic congestion. They often get some fibrotic changes in the fat right there because it's also getting compressed. And so that's what this picture is supposed to be showing. So this is the abdominal aorta. Here's the celiac artery. And so this is all of that dilated lymphatics and all of the fat that's all fibrotic right there. And then that all gets dissected away. And the median arcuate ligament gets cut so that it is able to expand a little bit more and not cause the compression. And then on clinical follow-up and evaluation of the PEEPs, in the surgical clinic, the patient said she was feeling much, much better, which happens apparently in about a third of patients. So what our surgeons will tell families is a third of patients with median arcuate ligament syndrome are going to feel better after surgery. A third are going to feel exactly the same. And a third will continue to have worsening abdominal pain because there's likely more going on than just the compression of the median arcuate ligament. So this is our protocol for targeted evaluation of MALs. Again, we want our patients to be NPO because flow velocities are going to be slightly different postprandial, so we want them in a resting state. And then we perform images of the aorta and the celiac artery with expiration just at rest, and then with max expiration and with max inspiration, and we do it both in the supine and the standing position. Now, I do want to point out, okay, that with many of these vascular compression syndromes, it is possible to see some of the morphology, the imaging findings, okay, of vascular compression, but especially in MALS, but also in the other vascular compression syndromes, the imaging findings have to be backed up by clinical symptomology for us to truly make the diagnosis. The two have to go hand in hand. So we can say that imaging findings are compatible with MALS, all right, but to truly make the diagnosis, this patient has to have the very specific clinical symptoms as well. Moving on to Thurner. So Thurner is a venous compression syndrome where the left common iliac artery crosses over, the right common iliac artery crosses over the left common iliac vein. And if the anatomy is just right, okay, that crossing artery compresses the vein and causes decreased flow or slow flow in that iliac vein. And this can result in chronic venous obstruction, which then can result in chronic thrombosis. There's also an underlying process happening where there's chronic irritation of the vascular endothelium from the compression as well. And so there results in some endothelial proliferation and hyperplasia. So there's not just the compression, there's also an abnormality happening within the vein itself. Clinically, these patients will present with unilateral leg swelling and pain and other signs and symptoms of venous stasis, like skin changes like you see here. So imaging evaluation consists of a combination of ultrasound with venous Doppler and cross-sectional imaging. So we will typically start with ultrasound first because they have a big swollen leg. So we're going to look at their venous system. And often it's the radiologist who goes, actually, this is Thurner, not just a regular old DVT, right? So on ultrasound, the Doppler evaluation is critical. And what we are typically seeing is near complete thrombosis of the left iliac vein and the common femoral vein by the time these patients present, okay? So when we're looking in this particular example, you can see that that left iliac vein is completely thrombosed, whereas the right is open. The other thing that you can look for, if it's not completely thrombosed, is loss of that normal respiratory variation in the deep venous structures, right? So even if you're doing a DVT study and you're not going all the way up, if you have loss of normal respiratory variation, you know that there's a more proximal venous obstruction. It's also really common to see a tangle of collateral veins in the groin or in the pubic region as the venous return is trying to reroute its way back to the systemic venous system around that obstruction. Cross-sectional imaging allows us to really make the diagnosis of the actual vascular morphology. So both CT and MRI, MRV are useful in the workup of suspected Thurner. So CT is more reliable or more readily available in some places. Dynamic MRV is really helpful for evaluation of slow flow. It's what we choose, but the imaging study that you do should be based on whatever is available at your home institution. And here's what we are looking for. So this is a dynamic MRV, and you can see that there's that crossing artery that's obstructing the vein, and there's no flow on our dynamic MRV. And then on the actual MRI portion, you can see that there's thrombus filling that renal vein, pardon me, that iliac vein. And then here you can also see on the CT in a different patient that classic morphology of this very, very narrowed portion of that left common iliac vein. Now, this is where that conversation that we just had about the symptoms having to match the anatomy comes in. Because if you actually really look hard at a lot of different abdominal CTs, you're going to see this anatomy, but you're gonna see it in patients who are not symptomatic. So you really have to match the two together. Conventional venography is our gold standard imaging still for both final diagnosis and then treatment of patients with Thurner. Intravascular ultrasound is growing in popularity from our IR colleagues. And since this is an ultrasound talk, I wanted to put it in here because I think it's really cool. And I'm kind of jealous that they get to do it. So this is actually an IVUS study that was given to me by one of my colleagues here at CHOA, Dr. Jay Shaw. And so to give you guys an idea of where we are, essentially the IVUS is coming from above, okay? And we're going to go down the iliac vein. And if the video runs, so here you can see us coming down the IVC. We're heading towards the direction of the left common iliac vein. You can see the artery cross over the top. And then as we come out of the compressed portion and into the thrombosed portion, you can see the echogenic thrombus within the vascular lumen. I just, as an ultrasound nerd, I think that that is so cool. And then this was the conventional venography. So you can see the degree of thrombus, and they did thrombolysis. And then the next day came back and most of the thrombus was gone. All right, so finally, we're going to finish up with Nutcracker syndrome, which is also sometimes called left renal vein entrapment syndrome or mesoaortic left renal vein compression. So similar to Thurner, similar to SMA, this is the renal vein, the left renal vein being compressed by the crossing superior mesenteric artery. All right, so that's this nice little cartoon where you actually have an old-fashioned nutcracker, and it's pushing, so that crossing SMA is compressing the SMV and causing venous obstruction. The venous obstruction leads to venous hypertension, which then leads to intrarenal and perirenal varicosities. And those varicosities can sometimes rupture, and that's what causes the hematuria that is the classic clinical presenting symptom for left renal vein compression. So the population prevalence of Nutcracker syndrome is not really well known, but the most common characteristic presentation is this left flank pain, abdominal pain, and hematuria. Okay. Sometimes you can also see pretty significant dilation of the ovarian or the gonadal vein as well, because it's also upstream of this area of obstruction. So ultrasound is often the initial imaging modality because these patients are coming in with hematuria. So we're getting a renal ultrasound. So we have our sonographers assess the left renal vein as part of our standard renal ultrasound if the presenting symptom is specifically hematuria. We also have a specific but much more limited Doppler evaluation if, let's say, there's been a CT scan and they questioned renal vein compression, and they're coming in specifically for that question. Because what we really want to see is the anatomy and morphology of the left renal vein in its relationship to the aorta and the SMA. So this is a recent case that we had. This was a 7-year-old, and on this really nice transverse image right at the level of the renal vein, you can see the anatomy and the morphology we're looking for. So this next picture has it all labeled for you. So what's nice here, you can see the aorta, you can see the SMA with its echogenic collar around it. Here's that left renal vein that's dilated, proximal to the crossing superior mesenteric artery. And then you can see that it is a much more normal, more collapsed caliber as it comes into the IVC. So we will also do Doppler evaluation of the renal veins to assess for that degree of compression. And again, what you're looking for is abnormal venous flow. You're looking for loss of phasicity to suggest that there's compression and some sort of disconnect between that vein and the central systemic venous system. And also if you see varicosities in the renal hilum or the perirenal region, you should think about it as a diagnosis. And then frequently, if they're coming from ultrasound, they will go to cross-sectional imaging. Sometimes it goes the other way. Cross-sectional imaging will suggest it, and then they come to ultrasound to see if it's truly physiologic compression or if it's just anatomy. But often we are doing CT for this indication at our institution. And what we're looking for is greater than 50% narrowing of the vessel. So we will actually do measurements on one side and then on the other side of that crossing SMA. Again, our interventional radiology friends get to play around with IVUS. And so here, if I can get this one from Dr. Shaw to play, you can see, and again, the course of this catheter is going to mimic the course that you see over here. So we're coming in from the IVC and we're headed towards that left renal vein. You can see the SMA come across. And as you come to the next little bit, it's much more dilated. And that's the big dilated left renal vein, okay? So this patient was taken for a diagnostic venogram. And the reason they do this is number one, to play around with their IVUS and have fun, but also number two, they're actually going to take pressure gradients in the renal vein between the IVC and then at the hyla. And that gradient can then be more diagnostic of the renal venous hypertension to really make the diagnosis. So this is our very specific Nutcracker syndrome protocol. So again, we're using this protocol when patients are specifically coming in for concern for Nutcracker syndrome. We do some limited images of the aorta and the IVC, but then we really spend quite a bit of time looking at the renal veins and really getting good Doppler evaluation of both the right renal vein and then the comparison left renal vein. But this picture is what we really focus on in making sure that we get a really good, nice trans picture through the middle of the abdomen. So you can see the aorta, you can see the SMA, you can see the portal vein, but then you can see that renal vein and you can assess for that degree of narrowing. Okay, so this becomes the diagnosis of both anatomy and flow, like most of them. So that's my little whirlwind of vascular compression syndromes with a focus on the ones that I see most commonly in our practice here at CHOA. And hopefully that was a focused and high yield review. And I'm going to stop sharing and we can open up and have discussion and questions.
All right. Thanks so much, Erica. That was awesome. I mean, if anybody in the audience has questions, feel free to direct those to me. I know I have some questions I can start us off with as well. So I had a couple questions. So the first was, you kind of mentioned that we have to kind of interpret these in the clinical context. I'm curious just about the verbiage you use in your reports. A lot of times we don't have a full history, or a lot of these patients, they kind of have this, chronic abdominal pain, more nebulous symptoms. It's really, I think, difficult to put the whole picture together sometimes. I'm curious to know how you handle those. If you have ultrasound, for any one of the different, syndromes you mentioned, but it's kind of unclear if it fits the clinical history. how do you handle that in your kind of verbiage of how you report those?
So frequently, I mean, the first thing that I do is obviously document the anatomy findings. So, list them all out. But the phrase I typically use is these findings could support a diagnosis of. I will frequently expand that, especially if I see that it's coming from a general pediatrician or somebody who may not, a practitioner who may not have as much experience with it. I just did this the other day with a case that came in from an outside hospital. It was from an emergency department. They'd gotten abdominal CT for abdominal pain, and the interpreting radiologist had questioned Nutcracker, and they got transferred to us, and we did the Doppler, and I said, yes, this anatomy can be seen with Nutcracker syndrome, but none of the physiology supports that diagnosis, and you have to closely correlate it with the clinical symptoms. And I'll actually list out the symptoms. I try to be a little bit more directive with this one. So.
Yeah, that makes sense.
Yeah. Does anybody do it differently? Judy, do you do it differently than that, or?
We get frustrated when we see things on CT because like it's almost normal anatomy, I feel like, to have left renal vein compression. So I like to see varices or some evidence that there's venous engorgement, you know what I mean? Which can be hard to see on, I guess that's more on the ultrasound. I'm sorry, the CT interpretation. So like I won't question it unless it looks like there's venous congestion because of that, like big narrow vein and stuff like that. On the ultrasound side, yeah, I like the verbiage that you use, can be seen when in the setting of, or like in the clinical context of, and that way they know they have to look for periods.
But I will say, this is one of those moments, because I work with a lot of residents and fellows, and when I was in residency and fellowship, I was taught to just say correlate clinically. And I don't let my residents and fellows say that anymore. I'm like, tell them exactly what to correlate it with. Because if you just say correlate clinically, if you get some people will know what you're saying, but not everybody. You can't assume that everybody knows what you know. So really, like radiology 4.0, that like correlate with this exact thing. So.
Yeah, I like that. Yeah, and then with Nutcracker in particular, some of the literature kind of differentiates between Nutcracker phenomenon and Nutcracker syndromes. I have kind of liked using that for like when it, like you had mentioned, Judy, with the collateral and all that kind of stuff. When I see that, I call it Nutcracker syndrome. I just see the compression of the left renal vein. Some people call that Nutcracker phenomenon and not really, make much of it. I kind of lean more towards that if it's just totally incidental.
Do you find that you're getting referrals from clinicians if you use that, or no? Like to then work up that imaging?
Yeah,
I worry about them not being able to distinguish.
Yeah, if they know what that means when I say that. Yeah, I mean it's not super common. I can't think of any that I've gotten specifically, further request to work that up, but I'm sure it probably causes confusion for some people. And then I had a question about the SMA. I've kind of wondered about the measurements you mentioned with the angle and the distance. I've kind of tried to figure out like the validity of those, and especially in younger patients. There's not a ton of pediatric literature, so I've tried to be a little bit cautious about that. But I don't know. Are you comfortable using that in really young kids, or do you mostly reserve that for adolescents, or how do you apply those measurements?
I mostly reserve that for adolescents, so age 10 above, which is the population that we tend to see this in, unless they have some sort of other confounding factors. But again, that's one of the ones where I say, well, it's definitely narrow, and it's definitely narrow, but again, you want to look for the secondary findings of the duodenal obstruction and, actually getting a functional study. Now, the better and better we get looking at our duodenum with ultrasound, I feel like the better and better we're going to be able to actually answer and make this diagnosis with ultrasound alone. At our institution, we're still working on getting our surgeons to believe that we can see the duodenum. So they still want an upper GI. And that's helpful too, because it's helpful for the families a lot, where you can say, look, it's really not crossing over. They can see it and they can understand that. But again, the measurements there are more supportive of,
Right.
not necessarily definitive for.
Right. And I think while you were answering that, there's a question submitted. So if the ultrasound criteria for SMA is met, but the fluoro study is normal, how would you, if there's no physiologic consequence of the narrowing, would you call that SMA or would you just call that normal?
I would call it normal.
Yeah.
If there wasn't physiology to back it up and there wasn't symptoms, I would call it normal.
Yeah, I agree.
Yeah, I feel like the more we do ultrasound, the more the angle is not as reliable to me for the SMA. Like, you know, it's invariably so narrow, and especially a lot of kids who maybe in California who are just naturally skinnier and dieting, you know, like they're just, they're not, and they're asymptomatic, they're not vomiting. So the angle itself is kind of, I don't know, it needs to be reevaluated. But I do have a question about like the measurements of the distance. So if you measure it to proximal where it comes off, it's always going to be really,
it's always going to be that way.
Because like it has to come off. So then I try to tell my sonographers to focus more on when it crosses D3, and we do give oral, whatever they want to drink as a team. So we give water.
I love that.
Yeah. So just water, well, nothing soda, I guess, and nothing that's like, carbonated because of the gas, but anything, any juice, whatever they want to drink, we'll watch it. And then it actually, we focus more on the distension of D3 and contents passing, the same as pylorus ultrasounds. Like if things pass through, then my suspicion is even lower, regardless of all the other measurements. And that has been kind of correlating with like them vomiting or not. And so I have found that to be helpful. But yeah, that's where I usually do my measurements, is after I get fluid to cross, and then I do it. But yeah, because otherwise with it completely flat and the probe like compressing on it, like I feel like it's always going to be less than like 10 millimeters.
Yeah, I agree.
Agree.
Yeah, I completely agree. Especially because in fluoro, that's our question, is looking for that passage versus not, especially with patient positioning. Like, why are we not doing that at ultrasound? I agree.
Yeah.
Yeah. Can I ask another question about measurements, but a different diagnosis?
Yes.
For median arcuate ligament syndrome, where exactly are you measuring the celiac axis? Like right at the narrowing, a little bit beyond the post-stenotic dilation? Like where do you put your
right? Are you talking about the Doppler? Where you're sampling the Doppler? So I treat this very much like I would any other stenosis, and I'm really I'm trying to sample as close to the narrowed part as possible, but just beyond it. So I have our sonographers get that really nice grayscale and colored dual screen picture to try to see the morphology. And I'm like, you see the little hook, and you want to get that Doppler gate box right where it starts to turn up. That's where I want to see it.
So then what do you do when you get these measurements that are like clearly beyond that, right? So there's going to be some turbulent flow, like no matter what, but what do you do when these measurements are so crazy high, like beyond that point? Not wrist hardest, right?
Yeah.
Which I'm like, what is happening?
I know. So I think of all the ones we talked about, median arcuate ligament syndrome is the hardest to image. I think it's the hardest one for your sonographers to feel comfortable with. And there was a question that was turned in kind of as a pre-question about how often do you go in and scan with your sonographer? Median arcuate ligament is the one where I still go in. I still go in so I can make sure that we're communicating together, the sonographer and I, exactly where the measurements are going to be. So I really can see it in real time and I can feel really comfortable and really confident. If I'm not available, one of our IR doctors actually goes in and does it because they're all pretty good at this too. The other compression syndromes that we talked about today, those my sonographers do all solo, but this is the one where, because it's impossible to know what to do in that scenario, I think. The other thing is to remember that, I went and had this conversation with our surgeon today to make sure I was going to say this right, because ultrasound is often our first study for median arcuate ligament syndrome, but it is not the last study that kid is going to get before they ever do any intervention. So 100%, they're all going to get a CTA. and 100% at CHOA. And, you know, politics is regional, your own institution is going to be different, but our surgeons really want a diagnostic angio too. And because with the diagnostic angio, frequently these kids are either awake enough to be cooperative and can do the inspiration, expiration, or they're under general anesthesia and we can do breath holds for them. Because we really want to see that when you're injecting contrast, that it really does have that dynamic change. Because the surgical outcomes in these kids aren't great. And so, you know, and our surgeons don't offer surgical intervention for all of these kids either, because we know that only a third of them are actually going to feel a lot better. So, you know, if the ultrasound is all over the place, but the kid really has symptoms that are suggestive of it, and they've really ruled out almost everything else, that's when we say, okay, the ultrasound is all over the place. It doesn't really say yes. It doesn't really say no. Let's move on to CTA and let's move on to the diagnostic angio so that we can have all that information before we actually make the next clinical decision for them.
Yeah, it's kind of interesting. One of our vascular surgeons I had talked to about this, she said in kids, she places the most stock in the Doppler ultrasound findings. She said she'll usually do a CT, but it's more so to look for like, you know, plaque or other reasons why they might have, which, you know, obviously wouldn't be as much of an issue in kids, but at least for, you know, our surgeons here, they are not as interested in the CT as they are in the ultrasound. One other thing I was going to mention about your diagnostic criteria you had mentioned for MALS, she had requested that we use the looking at the difference between the peak systolic velocity of the celiac between inspiration and expiration, and if it increases by more than 2.5, then that's, you know, what she's most interested in. Are any of you guys using that criteria? I know you had mentioned the difference between the aorta and the celiac, and then the absolute velocity. So we kind of say if it's more than 200 centimeters per second, either in inspiration or expiration, or if it increases by more than 2.5, then that's kind of what she's asked us to use for our criteria. But I'm curious if you guys have any other differences there.
We actually use a 3-to-1 ratio. So it's even more sensitive, or whatever. More specific, I should say.
Specific, yeah. Well, and I think this is also really challenging because it's a rare enough condition. And like we're like a dyed in the wool, follow that Gruber paper kind of institution. But that Gruber paper only had 6 patients.
Right.
So we don't have a big enough patient population of these just in general, I think, to really, I mean, yeah, we can use those numbers from that paper, and we do, but I don't know. It's hard to know just how well informed we really are still, even today. Yeah,
that was the other thing I was going to mention about the Nutcracker was that there's a similar paper that's, you know, it's pretty old at this point. It's like 7 patients, I think, but we use that paper. Like they have a couple criteria. They have if you measure the renal vein, like at the point where it's most compressed, if that's more than 93 centimeters per second, I think. And then if the difference between the velocity at the hilum and then that aorta mesenteric segment, it's more than 4.7, that's the other criteria. So we kind of put those numbers in there, but again, it's really hard to know what to do with those, like how accurate that really is.
It's really hard. Yeah.
Yeah, and I think that's one of the challenging things about these vascular compression syndromes in general is like, they're just such limited data, and I think they're very challenging patients to know what to do with.
They are. They really are. And, you know, it is helpful. It is nice to work at a big center, you know, because and even within my big center, I mean, CHOA, we have 20 general surgeons, but only 2 of them really deal with these syndromes, because we really want to make sure that it's very consistent and they're consistent and we're consistent for them. So that's something else to keep in mind if you're not working in a big system. So one of the other questions that you had sent me before, which I thought was a really good one, was a question about do you ever see patients with multiple compression syndromes kind of all together? The specific question that you had sent me was MALS and SMA. So I Googled it. There's like 3 case reports ever. So I think we can say that one usually doesn't happen. But superior mesenteric artery compression of the duodenum, those patients, there is an association with renal vein compression as well. If you think about it, it's the same thing. So of course you could have a patient with both. So I just wanted to put that out there because I had never actually thought about it. And then I Googled it and I was like, oh, that's so interesting. Yeah.
I had one other question about your SMA protocol. How often are you guys actually utilizing that? I've kind of thought about, we don't actually have a formal protocol for that here. I'd say most of the patients go to upper GI and it's infrequent. If they really want to evaluate the morphology, if they more typically here, they'll get CT. I feel like it might open a can of worms if you start offering that protocol. One of my colleagues was texting me while you were talking, saying we better not.
No.
I'm curious.
Why are we doing this? I don't want to do that.
Yeah.
Wow.
How often are you guys asked
to
do that SMA protocol?
Yeah, honestly, not very often. I think it will get offered up to families as an alternative to CT if they're hesitant to do the CT for any reason. I think in practice, we're only doing a handful of these a year.
Right. Yeah, I mean, we're kind of similar, like for the malls and the Nutcracker, like very uncommonly, I would say similar, like a few a year that we could actually do. But.
Yeah. And even within our own institution, like I'm probably the one who dictates these the most and interprets them the most because I have a specific interest in it. But I think we also, for consistency's sake, we try to have the same people interpret them.
Right. Yeah. And then the last couple of minutes, there was a couple other questions submitted in during the registration period about some other vascular compression syndromes that we didn't talk about today specifically. One was popliteal artery entrapment. We're not doing ultrasound for that. We only do MR. Are any of you guys using ultrasound for popliteal artery entrapment? Yeah, I mean, I think MRI generally considered better because you can look at the muscular anatomy and see, I think, a little bit better. Like we have a protocol where we do it in plantar flexion and dorsiflexion. So they're also very infrequent, a couple of years. So we're not personally doing ultrasound for that. The other one that I thought was kind of interesting, I'm curious to see what you guys have to say about it, is thoracic outlet. We went through this period where we were getting a lot of requests for it. And I think it's, the venous and arterial thoracic outlet compression, I think, is kind of challenging. The venous in particular, like it's so common to see if you do the dynamic maneuvers, like you're going to see that compression. I think there's paper says like 50% of asymptomatic, normal, healthy volunteers have some degree of venous compression. So we basically, we personally stopped saying we don't have a formal protocol for those. Like we don't do any dynamic maneuvers. Like we kind of similar to the Nutcracker. Like we just do our typical either venous or arterial extremity, like looking for, pseudoaneurysms or collaterals or any of that kind of stuff. Do any of you guys have like a dedicated thoracic outlet syndrome protocol for either arterial or venous?
No.
Okay. I'm glad I'm not alone there. And I think it's like the vast majority of them are going to be nerve compression instead. And like arterial and venous, I think it's pretty rare. And I think we were just kind of seeing it overutilized, I would say, or overordered. And it was, we used to have this very convoluted protocol where we would image the arm in like a bunch of different positions and kind of see how it's such a challenging protocol, I think, to do if you do it like that. But yeah, so we kind of just stopped doing it. We don't have a formal protocol for it anymore. But
we did a few, but they all went to either CT or MR afterwards to like look for, why is it being compressed, and like why are we struggling so much when easily insert with arms up, arms down at CT or MR. So usually MR.
Yeah. Right. Any other last minute questions from the audience? One other one I see here is that says most people believe that MALS is neurogenic and not vascular or ischemic as the symptoms improve with the celiac plexus block. So it says, are your surgeons asking you for imaging before surgery routinely?
Yeah, so I'm really glad that came up because that's part of, I alluded to it, but didn't go into details about, we do really believe as we're starting to learn more and more about MALS that there's multiple factors that are happening. We do offer celiac artery plexus or celiac plexus blocks at our institution, but it's part of the discussion of all the different options that these patients have. So they will get treated in terms of diagnostic workup, exactly the same. So our surgeons still want to see the anatomy of the vessels. They will still want to see inspiration, expiration, ultrasound, and diagnostic angio. But it's offered as part of their therapy too.